Good afternoon, and thank you for joining us for our third session of the day, Data Sharing Opportunities and Challenges, New Rules for ACOs. Just a couple of housekeeping items. If you'd like to make the presentation full screen on your device, hover over the presentation and hit that double arrow button circled in the green screenshot, in the screenshot below in green. And then if you want to ask a question during the session, over on the right side, you type your question box and then hit the green ask button, which is circled in red below. And you can type a question in at any time during the presentation. Now I'd like to turn it over to our moderator, Travis Broom, I apologize, at Aledade. Travis, all you.
That's right. I only wish I could be Tony Reed. Well, thank you all for joining us today to talk about really what the government, in the form of both the Office of the National Coordinator and in terms of CMS itself, is doing to help us move forward on sharing data between providers and between ACOs and with patients. So take us to the next slide, Anna. Oh. Anyways, so our objectives today are really threefold. One is to talk about how we learn if these new rules apply to you as an ACO, understand the framework of how the rules are applied to others, and then most importantly, learn how the ACO can leverage the rules to increase their own population health efforts, with obviously most of our time spent on that last one. Joining me today, I have Dr. Kent Locklear, who is going to kick us off and really talk about information blocking and moving forward from Lightbeam. And then I have Maria Nicola, who is going to talk to us about APIs. If you aren't familiar with that, it's basically the tool that makes all of your consumer apps talk together is APIs. That's why everything on your phone works so well. And she's from Salient, and she's going to talk to us about how that technology that makes everything work so seamlessly on your smartphone is now going to be coming to healthcare. And finally, I'm going to talk about the CMS conditions of participation rules, which basically require admission, discharge, transfer feeds whenever one of our patients hits the hospital or leaves the hospital. And then we'll have plenty of times for questions at the end from both you and questions I have for our panel. So with that, I will turn it over to Dr. Locklear.
Thanks, Travis. Thanks very much. Glad to be with this group this afternoon. I'm the Chief Medical Officer of Lightbeam Health. If you're not familiar with Lightbeam Health, first of all, you should become familiar with us. But we are a population health vendor and a longtime and proud partner of NAACOS. I'm going to talk about, as Travis mentioned, I'm going to focus on information blocking, but to cue that up, what are the Cures Act key objectives? And we can summarize those with 4 points. If you listen to Don Rucker from ONC and Seema Verma from CMS, you're going to hear them recurrently refer to these rules as focused on patient access. And so it's all about giving patients control of their electronic health data. If we can go back to the previous slide. And so that is the hallmark theme of both of these rules. In the ONC rule, and particularly relevant to information blocking, there is the establishment of some initial standards for the program, and this is what's referred to as the US CDI, or the US Core Data for Interoperability. I'm going to talk a little bit more about that in a few minutes. So for providers and for ACOs, this really should be viewed as a move in the right direction. There are many positives that are going to come out of these two rules. The one I'm going to talk about is, I think for most of us who've been around for a while, this idea of information blocking. It wasn't really necessarily called that in the past, but the result was the same, which was it was very difficult to exchange and share information amongst providers, between payers and providers, between patients and providers, payers and patients, in any case, in the entire environment. And then lastly, there are some changes to the ONC Healthcare IT Certification Program. We're not going to talk about that today. Next slide. So patient access, what is it? So it really is a very specific thing captured in this one sentence, giving patients a greater ability to electronically access, exchange, and use their electronic health information via internet-enabled devices such as smartphones. And so you're going to see these terms, access, exchange, and use. You're going to see that recurrently. You're also going to see the recurrent reference to electronic health information. So what does that mean? Initially, it is this US CDI. Again, I'll give you a little bit more information about that in a minute. Next slide. But the first thing I want to do is we just need to define information blocking. And it is a practice that is likely to interfere with that access, exchange, and use of electronic health information. So what are some examples? And this is where we can really start to understand. And I think you're going to relate to some of these because, as I mentioned, if you've been in healthcare and you've been doing anything with healthcare IT, you're going to recognize some of these. So information blocking is one example is practices that restrict authorized access, exchange, and use. So things that restrict the sharing of information between two technology platforms. So it could be between two EMRs. It could be between an HIE and an EMR. It could be between an EMR and a patient device. And that's where a lot of focus is going to go as a result of these rules. The second bullet, implementing health IT in non-standard ways that are likely substantially increase the complexity or burden. I can't imagine any of you have run into this. I mean, it's almost unheard of, doing things in non-standard ways in healthcare. I mean, come on. No, really, that's been a long-standing thorn in the side of both I think the healthcare IT industry and the provider population. And then implementing ways that are likely to cause problems. Next slide. So this is what the US CDI really is, and it breaks it down by class and by element. Some of these you're going to be very familiar with in terms of data that we already share pretty well. Things like problems based on standardized codes, ICDs, and SNOMEDs, procedures, things like laboratory results. Those are handled pretty well today. But there are some things on this list that have been challenges over time: assessment and plan of treatment, clinical notes, and oddly enough, something like smoking cessation, smoking status, can be challenging from a data sharing standpoint. These are all covered in the US CDI, and the expectation is that when these rules become active, which was scheduled to or should be scheduled to occur on November 1 of this year. We'll talk about some minor delays. But for the first 24 months, so going through May, so the rule was released May 1 of this year. For the first 24 months, this will be the data standard. Following that initial 24 months, the definition will expand to basically include all electronic health information and that will be defined over time. Next slide. So who are the regulated actors? They use the term actors in these rules. Who are the regulated actors? And it really is, and this is where we've seen a lot of confusion and a lot of questions. The three actors are the health information networks and health information exchanges. Now, just to be clear, these are not the technology vendors. So Lightbeam, for example, we have an HIE. We are not a regulated actor in terms of us developing and deploying HIE technology. it is our clients or the HIEs themselves that are the regulated actors. Now, obviously, the technology vendors have a responsibility to help our clients meet all the requirements, but the regulated actor is the HIN and HIE. Second, the HIT developers. So the developers of certified information technology. For all intents and purposes, if you talk to the leadership at ONC, this is the EMR vendors. There will be some significant exceptions to that, but for the most part, we're talking about the EMR vendors when we talk about HIT developers as it relates to information blocking. And then lastly, healthcare providers, which is, I'm assuming, a lot of people on this session. And so there are things that you will have to do in order to comply with this. Fortunately, the regulatory penalties have been delayed for the time being, and will be defined as iterations of this rule are released. We can talk about that a little later in the Q&A if that comes up. Next slide. And lastly, exceptions to information blocking. There are two big buckets. One is exceptions that involve not fulfilling a request. And then the other bucket is exceptions that involve procedures necessary for fulfilling the request. Obviously, in bucket one, we don't want to harm anyone through the sharing of this data. Always there will be privacy and security concerns. But unlike in the past where, without stepping on anyone's toes, where HIPAA has been used as a reason not to share information, that will no longer be accepted. These new rules are going to force decisions to be made, and for those privacy and security concerns to be weighed. When the weight falls in favor of sharing, that is going to be the expectation. And if there are patterns of using HIPAA as an excuse not to share information, that will be frowned upon under the terms of this rule. The second bucket, it's pretty self-explanatory. There will be some licensing requirements. There will be some costs and fees associated. And so those are our exceptions. And with that, I'll conclude my piece on information blocking. Happy to answer questions at the end.
Great. Great. Thank you, Dr. Lockwood, for taking us through that. Maria, so, we talked about how all this information is, has to be shared now. How are we actually going to share it?
Awesome. Thanks, Travis. And thank you, Dr. Locklear. So my name is Maria Nicole, and I'm a senior business consultant with Salient Healthcare. And in case you missed our presentation earlier, Salient Healthcare is a national performance management company that's focused on helping healthcare organizations confidently accept greater risk in their value-based contracts. So today I wanted to talk a little bit about the new rule. So the Office of the National Coordinator for Health Information Technology and the Centers of Medicare and Medicaid Services rules work together to enable the mandate for the Cures Act to drive the electronic access, exchange, and the use of electronic health information by and between patients, healthcare providers, and health plans. And one of the ways both rules carry out this mandate is by requiring and standardizing the establishment and use of application programming interface, otherwise known as APIs. So the CMS and ONC rules will enable smoother access and exchange of information through the use of common technologies such as smartphones, computers, tablets, and different applications. Important information such as personal health records are much easier to acquire from your doctor's office because of this. So ONC's final rule establishes secure standards based on API requirements to support a patient's access and control of their electronic health information. APIs are the foundation of smartphone applications, or what we call apps. And as a result of this rule, patients will be able to securely and easily obtain and use their electronic health information from their provider's medical record for free using the smartphone apps of their choice. And building on the foundation by ONC's final rule, the CMS Interoperability and Patient Access final rule requires health plans in Medicare Advantage, Medicaid CHIP, and through the federal exchange to share claims data electronically with patients. So let's take a look a little bit more about the API. So an API is a messenger that works behind the scenes to help software programs or servers communicate with each other. Most individuals have likely used an API in their everyday lives without even knowing they were using them. One example is that if you search for airline tickets on websites like Kayak and Expedia, they use APIs. Your financial banking institution's app uses an API, which is what we have depicted on this slide. Another real common example of APIs is when you look at Google weather on your phone in your area. You get detailed information of the hourly temperatures because Google uses an API to contact a weather service in order to gather that information for you. So let's take a look at the two APIs. First, the Patient Access API. CMS regulated payers, specifically MA organizations, Medicaid fee-for-service programs, Medicaid managed care plans, CHIP fee-for-service programs, CHIP managed care entities, and qualified health plan insurers on the federally facilitated exchanges are required to implement and maintain a secure standard based, so probably an HL7 FHIR API that allows patients to easily access their claims and encounter information, including costs, as well as define subset of clinical information through third-party applications of their choice. Claims data used in conjunction with clinical data can offer a broader and more holistic understanding of an individual's interaction with the healthcare system, leading to better decision-making and better health choices. So these payers are required to implement the Patient Access API beginning January 1, 2021, and they did push that back because of COVID by 6 months. And now let's talk about the Provider Directory API. So CMS regulated payers that were noted above are required by this rule to make the provider directory information publicly available via a standard-based API. Making this information broadly available in this way encourages innovation by allowing third-party application developers to access information so that they can create services that help patients find providers for care and treatment, as well as help clinicians find other providers for care coordination in the most user-friendly and intuitive ways possible. Making this information more widely accessible is also a driver for improving quality, accuracy, and timeliness of this information. MA organizations, Medicaid and CHIP fee-for-service programs, Medicaid managed care plans, and CHIP managed care entities are required to implement the Provider Directory API also by January 1, 2021 with the same 6-month extension, and the qualified health plan insurers on those exchanges are already required to make the provider directory available in a specific time-readable format. So now let's take a look at the maintenance documentation and security. Payers must also ensure that API functionality functions properly by conducting routine testing and monitoring and ensuring the appropriate privacy and security features. CMS does not define what is meant by routine, leaving this to payers, but expects them to practice best practices for testing and monitoring. Existing requirements under HIPAA continue to apply to payers as well as APIs. However, there's certainly lots of concern that the rule would lead to inadvertent disclosure of family history information and privacy of the dependents. CMS notes that a policyholder, for example, parent, could see claims for all members in their group, such as a minor, unless there are agreed upon provisions available and already in place. Payers must comply with the separate ONC rule, which requires APIs to meet certain technical standards and address standardized content and vocabulary for data available through the API. Payers can use alternative content and vocabulary standards for additional or optional data that is made available through the API. And for the provider directory API, the API does not have to meet certain authentication and authorization standards laid out by the ONC rule. These requirements are unnecessary because the provider directory API is publicly accessible data. Each API must be publicly accessible on the payer's website and accompanied by documentation on technical aspects. Payers cannot require a reader to pay a fee to access the documents and receive a copy via email, or agree to receive future communications making the documentation available. Payer must also allow third-party applications to access their API in general. However, payers cannot deny or discontinue a third party's connection to their API if the provider determines, using objective, verifiable, and uniformly applied criteria, that the connection poses an unacceptable risk to the security of its own protected health information. Payers should determine risk consistency and content with a security risk under the analysis of HIPAA. CMS declined to establish a vetting and certification process for third-party apps, or to allow payers to develop their own validation processes or place additional constraints on those apps. And under the final rule, payers can, but are not required to, request that a third-party app attest to having certain privacy and security provisions in their privacy policy before the payer provides access to that API. CMS identifies some of the attestations that payers could require, such as the fact that the app has publicly available privacy policies written in plain language that has been affirmed and shared with the patient ahead of time, and other components of the app's privacy policy itself. If the app fails to attest to these requirements, the payer must quickly inform the patient and allow the patient to cancel their request to the data that's being shared. And if the patient does not cancel their request or does not respond, the payer must still honor the patient's request and share that data with a third-party application. So how is this going to impact patients, providers, and vendors? The new rules are great for patients. It puts the patient at the center of their care by promoting patient access and use of their own health information and spurring the use of and development of new smartphone applications. However, they place a major burden on payers, providers, and health IT vendors, with each rule outlining specific timelines and compliance date. And for providers, the burden falls on their EHR to meet the majority of those compliance requirements. Among some of the most vocal critics of these rules was the Epic system. And they posted a long note, which you see on the slide, which points to a recent study showing that 79% of healthcare apps resellers share data, and quote, by requiring health systems to send patient data to any app requested by the patient, the ONC rule inadvertently creates new privacy risks. And earlier, the former Secretary of HHS, as well as the former Governor of Wisconsin, noted that where Epic is based, that the new regs would compel Epic to give its trade secrets away to venture capitalists, big tech, Silicon Valley interests, and overseas competitors for little or no competition. HHS rules would constrict Epic to work for these new entrants, subverting free market principles at the expense of Wisconsin residents. And that was published in the Wisconsin Journal. So for payers, they'll need to develop a strategy to hit these milestones over the next 2 years, a strategy that's going to take into account not just the near-term goals of patient and provider directory APIs, but how their organizations will manage and share data beyond just 2021. And this strategy is going to require key IT investments to ensure compliance requirements are met, and then balancing all of the privacy requirements. And of course, that will be extraordinarily costly. And many companies such as Apple, Google, and Microsoft are all proponents of this rule. And they specifically, quote, advocate that the 2 proposed rules should be finalized and released immediately. And with that, I will pass it back to Travis.
Great. Thank you so much. So all of these rules kind of came together in a package. And then there was kind of like this very, very important tack on that uses a completely different regulatory tool. And that regulatory tool is known as the conditions of participation in Medicare. And this is really the biggest hammer in all of Medicare's toolkit. If a hospital were to be audited and found non-compliance with their conditions of participation, and they could, in theory, be kicked out of the Medicare program. So everything we just talked about before are kind of new requirements through kind of new enforcement mechanisms. What we're going to talk about now is a new requirement through a tried and true enforcement mechanism. So, as people are want to, I didn't introduce myself very much at the beginning. I'm Travis Brum. I'm the Senior Vice President of Policy and Economics at Aledade. Aledade is a company that does, basically partners with independent primary care physicians across the country in ACOs. And I put this slide on here really both to tell you a little bit about our ACOs, but also because it so directly relates to what ADT is all about, admission, discharge, transfer, feeds out of hospitals. So our goal, and frankly, the goal of the value-based movement in general, is to be, find that sweet spot where we're doing good for society, reducing costs, good for patients, keeping them healthier and getting more services that they need, and good for doctors and other healthcare providers because they get to practice in a way that drives health and drives efficiency. And ADT fits all of that. Transitional care fits all of that. It is good for patients. We can now monitor, know when patients are literally at their most vulnerable time. It's one of the most vulnerable times in any patient's life is waiting to be picked up, sometimes in a wheelchair, sometimes ambulatory, essentially on the curb of the hospital and what comes next. It's good for those physician practices. It just strengthens the relationships with the patient. You want to strengthen a relationship, be there when patients need you. Call them, right before they're discharging and make a plan for that scary situation. Good for society. We're talking about reducing readmissions, reducing healthcare costs, and improving population health. So that is really where it's all about. I mentioned we have lots of ACOs. These are them. Won't read across this slide for you, but again, the idea, Aledade's whole principle is working with independent primary care practices and community health centers across the country in ACOs, both MSSP and commercial. Next slide. So again, to kind of put even more of a face on what we were talking about, are some quotes and some data about the importance of that patient relationship at this time. One of the things I tell our docs when we're working with them in our ACOs is really at its core, what is an ACO? An ACO is a group of physicians, a group of healthcare providers that came together and said, these are my patients. I'm going to be responsible for the cost and quality of their healthcare and their health. And that is really at the core of what an ACO is. And knowing where a patient is on their healthcare journey is so critical to being able to fulfill that promise of being accountable and responsible for a person's health. Next slide. So what is like the impact when we talk about readmissions in particular, right? So every year, nearly 1 in 5 Medicare patients are readmitted to the hospital. You guys can see this on your reports, right? In your quarterly reports that you get from CMS. There's, readmissions and expressed in rates per thousand. And that is a lot of people. When you talk about 1 in 5 Medicare patients, 2.6 million seniors costing $26 billion. And over half of those patients have no contact with their primary care doctor after discharge. They are discharged home to basically be their own care manager, to essentially fend for themselves. And that is a terrible situation, both from a cost perspective and from a quality of care perspective. And most importantly, it's not something that has to exist in 2020 anymore. So next slide, please. So this is, kind of an example of what can happen when you know. So this is, Alliday data. So all of these patients are in an ACO, right? So all of them have taken that kind of pledge, if you will, to be accountable. But those patients who have a 30-day readmission for high-risk patients with no transitional care management visit, i.e., no provider connection after that readmission or after that discharge, have basically what you see as national normal readmission rates, 14%, 15%. You can see from your quality reports, that's basically what it is. Those who do have that transitional care management, you can cut it in half, right? So you remember that slide, 2.6 million can become 1.3 million. 26 billion in spent can become 13 billion saved. Next slide. And again, this is not, while this slide looks kind of slick, this is not rocket science. So there's a reason we're using this old version, this old tool, instead of the new tool of conditions of participation, because there isn't rocket science either behind the technology of an administrative discharge feed or what to do with what you got. So what you're looking at is a very simple, stylized, nice looking call list, right? All this is because we now know, and you have to know to put somebody on the list. But once you know to put somebody on a list, that's where and you put somebody in charge, you make somebody responsible for, like, again, this accountability. We're accountable for these people. And this idea that we now know you left the hospital. So it is now on us to make sure that you get that transitional care that you need at this time. So this is the work list for them. And again, this is just information. It kind of looks cool. We've gotten better at our design. But at the end of the day, this might as well be on a piece of paper that says, call these people, because these people need you. Next slide. So what is CMS now requiring of hospitals so that we know people need them? And again, it's called administrative discharge transfer feeds. My old job, way before I joined Alliday 6 years ago, and frankly, it was at the center of Medicare and Medicare services. I wrote a lot of the meaningful use regulations way back when it was first getting going. And ADTs are the lowest hanging fruit. We hear all the time about the ATM example, right? Oh my gosh, I can get cash with my card in Dubai, even though I live in Bethesda, Maryland, when I'm on vacation or whatever, no problem. Health IT folks have always kind of graded at that example because the data elements necessary to get that cash are very few. It is a very simple transaction, whereas giving you your medical records is an extraordinarily complicated transaction. Do you know what is as easy as an ATM swipe? An ADT feed. There is no technical barrier for anybody with a certified EHR. But we're still running into barriers. So making it a condition of participation is how CMS is basically putting their foot down and saying, guys, we've been working on this for literally 12 years. It'll be since the Recovery Act was passed. And we're still not at 100% for what is the easiest piece. So, as a condition of participation in Medicare, hospitals will be required to send admission discharge transfer data. And again, keeping it simple, the most basic data. This is the person, they showed up at this facility on this date. We transferred them between units on this date and time, and we discharged them on this date and time. They can send more, but that's all they're required to do, is to make you aware, and you being primary care providers of practices that have an established relationship with the patient. ACOs are in a great place for this. We literally have a list of patient relationships, right? Every day, CMS literally sends you a huge file that says these patients are related with Aledade, Louisiana ACO, or other people that the patient may identify. So this is kind of comes in two ways. One, providers can establish that relationship with hospitals, or two, the patient can identify. Again, minimum information required. Obviously, we would love more. We'd love to know the diagnosis. We'd love to get the discharge plan, all those things. But to keep it simple and to make it a condition of participation, it is the minimum information required is patient name, treating practitioner name, and sending institution. How? So there's basically two ways that this can happen. You can set up a direct link with the hospital. Sometimes hospitals have portals. Sometimes they might send you an HL7 transaction right away, or they can use those health information exchanges that Dr. Locklear was talking about, or they could use another third party. The important thing for anybody who has a hospital on this end to realize is that if you use a third party, you can't then delegate all these requirements to the third party. You are responsible for the performance of that third party because you are the regulated actor. You are the one who are subject to conditions of participation, but you can absolutely use a third party as long as that third party is delivering the service as required. When? May 21st, 2021 is a little later than some of the dates you have been hearing about and some of the other rules. Again, because CMS broke out its biggest stick, it is giving hospitals the most time on this one, but it is around the corner, May 2021. Next slide. So I kind of covered this already. Should have waited for my slide. I got ahead of my slides here, but ways to send ADT data, again, direct connection through an ACO, or through an HIE, a private company, et cetera. There's vendors out there who do this. There's lots of state-run HIEs who either do it in-house or have a vendor themselves. Just for perspective, we get basically millions of ADT notices a year. Over 90% go through intermediaries, both private companies and HIEs. Only about 10% are direct. And that's for the obvious reason of even in a medium-sized community, there's going to be several hospitals. They're going to have different EHRs. Patients are spread out, et cetera. This is an area that's ripe for efficiency from an intermediary. Next slide. This is just kind of a very recent example of what the power of ADT. So this is Aledade's ADT alerts over time. If I took out the dates, I'm sure you could still tell me what the dates were on the bottom, right, of when COVID hit. And you can see this has been an early surveillance of, what's going on with COVID-19 and hospitalization use. And then it's also made it even more important, right? Obviously there was some electiveness. There's some electiveness in hospitalizations. But that just means that every one of those hospitalizations that did happen in the bottom of that trough and is happening today becomes even more fraught and even more in peril for the patients to do it well during the time of the pandemic. But you just show you the power of this data. I mean, a lot of ADT feeds are virtually real time. Exactly out of the movies, like you would think of, high-risk patient is discharged from the hospital on Saturday at 5 p.m. Hopefully a hospital wouldn't do that, but let's say they do, they put it in the system, it can ping a physician's phone with a text message, just like that. Again, there are a lot of very, very complicated parts of health information exchange that almost have no parallels in the consumer space. This is not one of them. This is the simple one. This is the ATM extraction. So that brings us to our final slide here. And again, it's just now, right? This is beyond savings. It's beyond market dynamics. In 2020, this should be the standard of care. Every certified EHR technology can send ADT feeds. They've been able to send ADT feeds back from when I was writing their rules for them back in 2009, 2010. Every ACO knows who their patients are. If you can't figure it out yourself, CMS sends you a freaking list, right? Everyone knows their patient relationships, and really everything else is just a prioritization excuse. this is something we need to do now for our patients and work with our providers. And with that, I'm going to turn it back over to Dr. Locklear for kind of our first question. And my first question is really for him on, how have you seen ACOs utilize an ADT feed in the real world?
So Travis, as you so nicely articulated, ADT technology has been around for many, many years. It even predated your work at CMS and or ONC, and it is simple technology. And so there are examples that predate this new rule where ACOs have been able to, through a relationship with the appropriate hospitals, been able to obtain this ADT information and then leverage that in an initiative to try to address unnecessary utilization. If you've got my slide, the next slide, you can pull that up. One of our partners who is an NAACOS member and an ACO, Princeton Health, they have been using ADT information to drive a specific care management program around transitions of care. This has been going on for quite a few years now, and here are their results. And I think these are pretty striking results, pretty enviable. So they were able to reduce total inpatient admissions by 15%. They reduced inpatient spend by 4%, reduced readmissions by 6%, and received the highest quality tier for one of their commercial contracts. So what are the requirements? First of all, you have to have that information from the hospital. The reality is, in many communities, that has been an issue in the past. The willingness or unwillingness of that hospital to provide that information, and as Travis mentioned, in many cases, I would have viewed it as excuses. They would say, resource restraint, constraints, or whatever whatever the issue happened to be. But at the end of the day, this was important information to share, and it wasn't getting done in many cases. And so now with this rule, there'll be no more excuses. It will be a condition of participation, and there will be a pathway to alert the appropriate authorities if hospitals are not complying with the rule. And so our hope and really our belief is that this simple technical transaction is going to drive tremendous change and tremendous opportunity out in the provider and healthcare space.
Thank you so much. So, Maria, we've been talking about how we've are going to get ADT information out of our hospitals, texted to our phones and things. At what point are we going to be using these plan APIs to get our claims data for our ACOs?
Yeah, good question. So hopefully patients are going to be able to receive some of these notifications, and all of it is going to be in one single system. And so that there's a little bit more of that communication and exchange that really happens. Accountable care organizations right now really need data to easily be able to exchange between hospitals, physicians' offices, and other community providers. And if that data exchange doesn't happen, then that care coordination and care management really becomes really difficult.
I know there was CMS has been experimenting a little bit with trying to do an API to replace ACO's CCLF reports. It's kind of, if you were curious, one of our questions is, what can an ACO do to kind of get ready for both ADT feeds and these APIs? I think for ADT feeds, it is really, a simple transaction, HL7 type transaction. And a lot of it is just making that relationship with either your HIE or hospital. But for these APIs, I don't know if you guys have any specific advice for ACOs of how would an ACO get ready to make the transition between a CCLF flat file, like we're used to getting once a month in our, uber secure, it feels like whenever I log into it, EFT files to a true API.
Yeah, I'll take that one. at least first off. So actually, Salient is working right now with one of our clients in a pilot to be able to get that data from the API into our system so that, again, it's a little bit more real time. All of that complexity is eliminated, hopefully, with the use of the API. So more to come on that, and we're gearing up, and I recommend others do the same.
So Dr. Locklear, what are you guys thinking about ACOs?
Well, we're actively working on developing that API, developing the capabilities to take in that API. We're not fully prepared because there's still some missing fields in the API data versus the CCLF. We're not ready to make a full transition, but we're putting essentially the plumbing in place to be able to do that, to use it as an alternative to the CCLF. And then at some point, we fully expect that there'll be a transition completely from the CCLF to this API. If there are audience members out there that are interested in this, I think this is, this would be a place where, in a self-serving fashion, I would say, if you don't have a vendor who can help you with this, then maybe find one, and you can look at this short list here as maybe some opportunities to help you with that. But I do think not only do you have to be able to take it in, but you have to be able to process it appropriately and give it to the right people. So there's downstream steps from it as well. So
absolutely. Can't put our flat files into Excel. We're not going to be putting our API files into Excel either. So Dr. Locklear, stick with you for a second, just because I think it's a really important point that you covered in your presentation, but to make very clear, since most of our audience is a member of or runs an ACO, is an ACO a regulated actor for the rules?
Well, so that's a very, very good question, and I'm going to try to, it has some nuances, and I'm going to try to answer it the best I can. From an ACO perspective, your providers, and obviously your providers and your practices, they are actors. They are healthcare providers, and they are actors under this. So, I know there are different relationships under an ACO umbrella, but with no uncertainty is from that perspective, the providers and those practices, they are considered actors and will be expected to comply. Now, I did mention that, and it's an important distinction between the HIEs and the developers. The enforcement for the provider, the healthcare providers under information blocking, has not been fully defined. In fact, they deferred even describing enforcement. And they carved it out. So enforcement in terms of HIEs and healthcare IT developers will be handled through the Office of the AIG, and there are some eye-popping potential fines of $1 million for those found guilty of information blocking. The OIG will not be the agency regulating the providers. They're going to assign another agency. There have been no enforcement rules and regulations or fines established, but they are expected to come. So that's one side. Could an ACO be defined as an HIE? The answer to that is yes, and you would have to look at the way that ACO, if that ACO is compiling data and holding it in some fashion, and then distributing that data in a secondary fashion. So they're taking it in, the primary action is compiling that data, and then they're distributing that data to other entities, or even within their own entity. They could potentially be viewed as operating, quote unquote, a private HIE. HIE is not defined by the technology, so you don't have to have, quote unquote, an HIE vendor or an HIE solution. It's the process, compiling the data and then distributing the data. And so if ACOs are operating those sort of technology-based platforms, taking in electronic data, compiling it, and then redistributing it, they should evaluate this rule carefully, because again, some of the requirements and obviously the enforcement is different than it is for the providers.
Yeah, one of the things we've thought about as we're looking at these rules and kind of went to ONC for clarity about, like, you know, you shouldn't be allowed to, and you should start, if somebody tells you you have to, certainly reach out to the ONC and get clarification on that. But it's our understanding that, you know, plans or other parties, right, shouldn't be able to use ACOs as kind of like a shortcut or a clearinghouse to get to the actual healthcare providers behind the ACO. If what they really want is a connection to the healthcare provider, then they should go to those healthcare providers directly.
Yeah, I would agree with that.
Yeah. Maria, you know, I don't know everybody else's experience, but my experience with commercial plans and getting claims data and flat files has been mixed, is probably the best way to put it. So what happens if a health plan can't comply with the requirements of an API?
Yeah, so obviously health plans are required to comply, and we've certainly had our fair share of experience of receiving data from health plans. With that being said, they are required to comply and otherwise face penalties, but there are exceptions to the rule. So if they really can't comply, the final rule includes a potential exception for qualified health plan insurers. If a qualified health plan insurer does not believe that they can meet the rule's requirements, it must include a written justification in its application. The justification should address why the plan cannot satisfy the requirements, the impact to the enrollees, its means of providing health information to enrollees, and a timeline to come into compliance with those standards. And the federal marketplace can grant the exception if it determines that the qualified health plan, even without API functionality, is in the interest of the potential enrollees. So definitely there's an out, but certainly hoping that they're able to deliver that information.
Yeah. So several of our questions have come in or have been kind of around the excuses that Dr. Locklear and I mentioned about ADT. You know, like, you know, will the ACOs, will this allow me to bypass my state HIE? You know, my state HIE requires a certain amount of providers to make an to even request an exception, or, you know, I have an ADT, but I'm paying a lot of money for it. Is this going to make it cheaper? You know, other ones that, you know, we certainly encountered are kind of like, you know, you can join the HIE, but you have to set up a clinical quality interface to be a member of the HIE and to get access to the ADT feeds. So, you know, with kind of those specific examples in mind, you know, what do we think? What do you think? And I'll ask this to both of you. Maybe Dr. Locklear, you go first, and Maria, you can chime in as well. Of, you know, how are hospitals and their intermediaries? All these questions, most of these questions were about HIE. How do you think that they're going to respond to kind of moving past some of these onerous requirements now that it's a condition of participation?
Yeah, I'll take that first, because we're really actually starting to touch on information blocking here. So if a circumstance exists where there are lots of onerous requirements in terms of joining that HIE, or fees that seem to be prohibitively expensive, they're going to be, it can be identified. Someone can raise their hand and say to the Office of the Inspector General, we think this is an example of information blocking. And then someone will do an investigation and they will say, you know what, this does not meet one of the exemptions. You know, your policies are overly excessive, They're beyond what would be considered usual and customary, and it could be evaluated as an example of information blocking. And I think this is where the dynamic is going to change. Just being able to say we're going to charge X amount and you have to jump through all these hoops, that is not going to be, I can just say, it's not going to be viewed favorably. Um, and so there's going to have to be a reevaluation in all the terms of all of these relationships. I am not aware of any published specific numbers, X amount of, you can charge X amount per patient or X amount per transit. I just don't think those exist. I think it's going to be the accumulated weight of evidence one way or the other. And then there may be an opportunity for remediation before it were to actually go to the penalty phase, let's say. But because I think the intention is to promote an environment where parties are working well together and not turn this into a big policing effort. I'll let Maria jump in and give her thoughts as well.
Yeah, I absolutely agree. The goal is to really improve post-discharge transitions and also reduce the likelihood of complications from inadequate follow-up. And these notifications are really designed to inform the provider that the patient has received care elsewhere. And so hopefully this leads to increased collaboration and care coordination and care management to really improve patient care. And really the rule puts the patient at the front and center of focus. So the idea that it's going to be really just too expensive or cost prohibitive hopefully will go away and makes this exchange significantly easier.
Yeah. I think, I'll add my 2 cents here too on this one is, I think a good example, again, they can use intermediaries, but intermediaries have to fulfill the duties, right? So you go to your hospital and say, I would love to get ADT feeds, from you. And they say, great, go talk to the state HIE. And then you go to the state HIE and they say, well, unless you have 150 doctors, we won't connect to you. That's now you have the opportunity, right now, today, that's kind of the end of the discussion. Come May, you'll have the opportunity to go back to the hospital and be like, you can't send me to the HIE because the HIE can't meet the rules because there's no minimum number of providers required to set up, an ADT feed. I mean, one's technically enough because it's all about the patient relationship with that primary care provider. And I'd really encourage all of our ACOs to really view this as an opportunity to build stronger relationships with your hospitals. I mean, again, this is a condition of participation. I know most of you haven't worked in Medicare, but if you worked in hospitals, you know that what a big deal this is. So you can go to a hospital and basically say, like, look, you got this new condition of participation, big, mean, bad CMS, and you say, like, but look, I've literally got this CMS list of patient relationships, and I can take in the data however you like to send it to me. We'll keep it simple. I can be I literally have a list of 15,000 people that you can be instantly compliant with. And I can update that list for you in the way you like, every month, every quarter. And, you now have to do this, and I am your best partner in the world at this because, outside of me, how are you going to prove patient relationships? Patient sticks a doctor's name on the form, and now, you got your staff like Googling them or something to try and find them. Here we can be, it is, I'm not saying this will win over every hospital, but every hospital now has this requirement, and there is no better partner in meeting this requirement than an ACO, because only ACOs both have the wherewithal and the established patient relationships with that many people. So we got 2 minutes left, and I think I'm going to give a minute to each of you to really kind of encapsulate what do you see as the greatest opportunity for ACOs in these new rules going forward. Maybe Maria, will start with you.
Yeah, sounds good. So Under the final rule, certain hospitals and critical access hospitals must comply with the new electronic notification requirements. And again, these requirements and notification must comply with HIPAA and other privacy rules and are designed to inform the receiving provider that the patient has received care elsewhere. And again, the goal is to improve post-acute discharge transitions. While I think that the rule pushes the industry in the right direction to increase access to data, it's imperative that HHS listen to the needs of the providers in value-based care models and reprioritize also the provider-to-provider data exchange. And due to lack of consistency of interoperability, ACOs have had to really work around this issue in the past, which has really been a tremendous burden. And as it relates to APIs, the wider use of APIs and easier access to data through APIs will really help ACOs who today must deal with lots of disparate EHRs. Lots of them have between 15 and 10 to 15 EHRs, and it's really costly to access and exchange data at that level. And providers often struggle to receive that data from disparate systems, which results in a lot of workflow issues, which will hopefully start to become alleviated.
Great.
ACOs and patients, a couple more thoughts real quick.
Sure. Yes.
So as ACOs and patients have the ability to work together now, hopefully previously a lot of those patients were unaware that their practice was really part of an ACO, and now ACOs have the ability to kind of create maybe their own apps to connect together, and also use push notifications to cut down some of those no-show rates, empowering their beneficiaries a little bit more. So hopefully we'll get a little bit more patient buy-in as these apps become more prevalent.
Awesome. So lots of opportunities there. Dr. Loeffler?
Yeah, three quick points. One we've covered in depth, and that's the ADT event notifications. I think the opportunity is tremendous there. We've covered that. Number two, I think that the rules around information blocking are going to release. It's not going to happen immediately, but it's going to release what I would describe as the pent-up demand for the free communication of information, certainly amongst the healthcare provider community. I think it's going to remove those unnecessary impediments. I think we've gotten through the phase where some unnamed enterprise vendors were putting up a lot of resistance to this. I think we've pushed through that. Obviously, the rule is now out, and I think we're going to see that data freed up in a way that's going to really improve the way we care for patients. And lastly, and this touches on Maria's last point, the providing the direct access to the patients with their mobile device, which is again sort of the hallmark theme of the rule, is going to revolutionize patient engagement. Again, it's going to take some time, but it's going to release, I think, an app economy and an app environment that'll stimulate a lot of entrepreneurial, a lot of innovative activity, and it's really going to change the way patients can begin to engage in their own healthcare.
Awesome. Well, thank you so much to both of you for joining today on this panel, and we're all very excited about really health information technology in the future. I mean, I was did my graduate thesis on patient-driven value-based outcome 15 years ago, and got out in the real world and realized all the information we assumed people would have, nobody had in the real world. But now that world where we all can have access to the information is coming, is here, and a lot of ACOs are using a lot of great information today, and it's going to be even more robust in the future. So thank you again for joining us today, and I'm going to turn it over to Anna to wrap up the session for us.
Excellent. Thank you all so very much for joining us. Thank you to all our speakers. That is the end of today's sessions, and we hope that you all will join us tomorrow morning as we start the third day of our conference at 11:45 a.m. Thank you so much.